Okay, let's unpack this. Imagine you've just received that urgent trauma call, bleep. A 25-year-old man who fell 3 stories is en route to the ER. Your mind races. What are you looking for? What's your immediate game plan? How do you even begin to assess the damage when the patient is right there in front of you? Today, we're taking a deep dive into the foundational principles of fracture assessment and management. And look, this isn't just about, spotting a broken bone. It's about understanding the nuances, the whys, and all those critical steps that follow, really guiding you through those high-stakes moments.
Yeah, and what's truly fascinating here is how much crucial information is packed into that initial presentation and how a systematic approach to care can literally change outcomes. Our mission for you, our listener, is really to equip you with those essential concepts, the nuggets of knowledge that will guide your diagnosis and management of patients with fractures and dislocations. Think of it as your shortcut to being well-informed, helping you connect the dots faster.
Exactly. And to make these, let's face it, sometimes complex concepts really stick, we'll be using clear definitions, some memorable acronyms, and maybe even pose a few thought-provoking questions along the way. We really want you thinking critically, and yeah, we'll circle back to those answers as we go through our deep dive. Okay, so let's begin by setting the stage. Defining the key players in musculoskeletal trauma. First up, sprains. So, when we talk about a sprain, what we're describing is damage to a ligament, those strong, fibrous bands that connect bones together. This damage can be anything from just a few torn fibers, which we might call a sprained ligament. Its continuity is intact, it's still largely functional, all the way to a full rupture.
Right, a rupture means the ligament is completely torn and, well, non-functional.
Yeah.
And you'll commonly encounter sprains in places like the ankle, the knee, or maybe smaller joints in the hand, like the thumb. And for that initial treatment, there's a really easy to remember acronym that sort of acts as your immediate response team.
Police.
Police. Okay, what does that stand
It
for?
stands for protection, optimal loading, ice, compression, and elevation. That's a great anchor. But, here's maybe a clinical pearl. While police is that immediate response, that optimal loading phase, I think that's where many people can go wrong. It's not about immediate, strenuous activity.
No, definitely not.
It's more about applying gradual, controlled stress
Right.
to promote proper fiber alignment and strength during healing. It's a key distinction often missed, I find.
Absolutely. Too much too soon or even too little for too long, both can actually hinder recovery. It's a balance, such a critical point. Okay, moving on, we have two terms often confused, but they are distinctly different: dislocation and subluxation. So a dislocation means there is absolutely no contact between the articular surfaces of a joint. The joint is completely out of alignment, kaput.
Completely out. Got it. And subluxation, then, on the other hand, means there's only partial loss of contact between those surfaces. So it's not completely out, but it's definitely not seated correctly either. Wobbly, maybe.
Yeah, wobbly is a good way to think about it. And finally, the main event for our deep dive today: fractures. A fracture is simply a break or a discontinuity in a bone. It happens when mechanical forces exceed the bone's ability to withstand them, and you'll often see it abbreviated with a hash symbol, just as simple, hashtag.
Right, the hashtag fracture sign. And importantly, fractures aren't always just the bone itself in isolation. They can involve the joints, too, leading to something called a fracture dislocation or maybe a fracture subluxation. These are definitely more complex injuries that demand even greater attention, wouldn't you say?
Oh, absolutely. Much more complex.
Okay, all right. Future diagnosticians, here's our first little challenge for you. You're looking at an x-ray. What's the one symbol or term that, no matter what else you see, immediately tells you this is a bone injury, clearly differentiating it from just a sprain or a pure dislocation? We actually just mentioned it. Think about that, and we'll confirm it in a little bit. So bones can break for, well, various reasons beyond just a big impact, a big fall. Let's dive into the causes. We tend to classify them broadly as trauma, pathological, insufficiency, and stress fractures.
Okay, starting with pathological fractures. These are unique because they happen in bone that's already abnormal, sometimes spontaneously or often following only very minor trauma. Think of it like a structural beam that's been weakened by rust. It just crumbles under a load it should easily bear. Causes can include tumors, benign or malignant infections, or even generalized metabolic bone diseases like Paget disease. So, for instance, you might see a pathological fracture in a vertebra that's been weakened by breast cancer metastasis. The bones simply can't handle normal stresses anymore.
Makes sense. Then we have insufficiency fractures. Now, these are actually a type of stress fracture, with osteoporosis being the most common underlying cause. They result from multiple minor events causing a cumulative load on already weakened bone. So it's not one big hit, but lots of small stresses adding up over time, sort of eroding the bone's integrity until, bang, it eventually gives way.
And very closely related, but still distinct, are fragility fractures. These are caused by a single event of minimal trauma. We're talking falling from standing height, or sometimes even less. They typically occur in the wrist, the spine, and the hip, those key areas for age-related bone weakening.
So the key difference is cumulative stress versus a single minimal event, even though both involve weak bone.
Exactly. Insufficiency is repetitive minor stress.
Mm-hmm.
Fragility is one minimal event on weak bone. It's a subtle but important distinction.
Got it. And finally, stress fractures. These are due to repetitive, nonviolent stresses, but this time on normal bone, often from overuse. The classic example, maybe you've heard of it, is a march fracture, commonly seen in young adults, maybe recruits, walking excessive distances. It typically affects the second metatarsal bone in the foot.
Yeah, picture repeatedly bending a sturdy wire.
Oh.
It's not one big snap, right? It's many small stresses accumulating until the material just fatigues and finally breaks.
Okay, that covers the why. Now let's talk about how we actually describe fractures precisely. This gives us a common language for diagnosis, treatment, and importantly, communication among clinicians. So key descriptive categories include things like open or compound versus closed, simple versus comminuted, displaced versus non-displaced, the anatomical site, complete versus incomplete, and also the background bone texture.
Let's focus first on open compound versus closed fractures, because honestly, this is a critical distinction, a huge one. An open fracture means there's a direct communication between the fracture site and the external environment. A break in the skin leading down to the bone. And this isn't just a cosmetic difference. It dramatically increases the risk.
What are the specific concerns then?
Well, the big ones are significant skin and soft tissue damage, potential neurovascular injury damage to nerves and blood vessels, and crucially, a very, very high risk of infection. We even classify them further based on the extent of that soft tissue and vascular damage.
Absolutely. You're so right to emphasize this. You really should think of open fractures as a code red situation, an emergency. They require immediate aggressive management. Cleaning, irrigation, reduction, IV antibiotics are essential. Check the tetanus status, often followed by surgical debridement or washout and then fixation. It's an emergency with immediate and multi-pronged treatment, really because the stakes for infection and long-term functional loss are just so high. What's maybe the most common mistake you see clinicians make when managing these initially? Is there one?
That's a good question. I'd say a common pitfall is sometimes underestimating the extent of the soft tissue injury just by looking at the skin wound, or perhaps not administering those broad-spectrum antibiotics quite promptly enough. Time really is tissue in these cases, and getting that rapid, thorough debridement is so key to preventing devastating infections like osteomyelitis.
Right, osteomyelitis. Definitely want to avoid that. Okay, next distinction. Complete versus incomplete fractures. A complete fracture goes all the way through the bone, complete separation of the cortex, it's fully broken into two or more pieces. An incomplete fracture, well, as the name suggests, means the whole cortex isn't broken, it's still partially intact on one side.
Exactly. And for complete fractures, we then describe the shape of the fragments. We have transverse, which is straight across the bone, oblique, which is an angled line across the bone, comminuted, meaning it's shattered into more than two distinct parts, and spiral, which look like a corkscrew, often caused by rotational forces.
And the incomplete ones.
Right. For incomplete fractures, which we see more often in kids because their bones are more pliable, we typically see buccal or torus fractures. That's a compression injury causing a bulge, kind of like crushing an empty soda can vertically.
Yeah.
And the other classic one is the greenstick fracture. That's where the bone splinters on one side, the tension side, but doesn't fully snap through on the compression side, just like trying to break a young green tree branch.
Ah, that's a great visual for greenstick. Okay, so let's circle back quickly to our earlier questions. If you saw that hash symbol, hashtag, on an X-ray report or in notes, you'd know immediately it signifies a fracture.
Right?
Okay?
That's the universal shorthand.
And if you were describing a fracture that shattered the bone into multiple pieces, more than two distinct fragments, the specific term you'd use is
Comminuted. C-O-M-I-N-U-T-E-D. Comminuted.
nailed it. And these precise descriptions, they're really vital for guiding treatment, aren't they?
Absolutely vital. Tells you so much about the injury, severity, and stability.
Okay, one last descriptive category, fracture displacement. This describes how the distal fragment, the bit further from the body center, has moved in relation to the proximal component. And we quantify this by shortening or distraction that's measured in millimeters, showing how much the bone has either overlapped or pulled apart. Then translation, expressed as a percentage, describing movement anteriorly, posteriorly, medially, or laterally, side to side or front to back. Angulation, measured in degrees, like saying 30 degrees of lateral angulation. And finally, rotation, also in degrees, either internal or external rotation.
Yeah, that precise quantification really helps determine the severity and informs the approach to reduction, getting it back in line. Okay, so now let's connect all this descriptive stuff to how the body actually repairs itself and how we as clinicians intervene. There are essentially two main mechanisms of bone healing. Secondary bone healing, which is often called indirect healing, and primary bone healing or direct healing. Secondary healing is by far the most common. It doesn't require perfect anatomical reduction or super rigid stability. It often involves non-rigid fixation, like casts or fracture braces, and proceeds through a process called endochondral healing. It's fascinating, actually. A cartilage callus forms first, like a scaffold, and then that slowly ossifies, turns into new bone. Very similar to how bones develop in the embryo.
Nature's way, mostly. And then the other type, primary bone healing.
Right, that's less common. This method demands very precise anatomical reduction, getting the pieces lined up perfectly in extremely stable, rigid surgical fixation, usually plates and screws.
Okay, so to visualize this, maybe consider joining two perfectly cut pieces of wood with strong glue, ensuring direct contact and absolutely no wobble for a seamless fusion.
That's a great analogy. It bypasses that cartilage phase and heals directly with bone formation across the fracture line, but it needs those perfect conditions. Okay, let's loop back to our scenario. The 25-year-old man who fell 3 stories. You're on the trauma team. Your very first approach, even before you're thinking specifically about a fracture, has to be a systematic trauma assessment, following the ATLS protocol, Advanced Trauma Life Support.
Right, the classic ABCDEs.
Exactly. Airway maintenance with C-spine protection, always protect the neck first. Breathing and ventilation. Circulation and hemorrhage control, stop any major bleeding. Disability, have a quick neuro check. And finally, exposure, get the clothes off to see everything but keep the patient warm. This is all about stabilizing any immediate life-threatening injuries first. Fractures can wait a few minutes if the airway is compromised.
Critical first steps. Okay, so only after that ATLS primary survey, once you know the patient is relatively stable, then you move to a more specific fracture assessment. And this involves getting a thorough history, understanding the mechanism of injury, how exactly did this happen, and the energy involved. Was it a high-energy fall like this one, or a simple trip? Then a detailed examination. This involves that systematic look, feel, move, plus any special tests pertinent to the area. You look for obvious things like bruising, swelling, deformity. You feel carefully for bony tenderness right at the fracture site, and crucially, for crepitus.
Ah, yes, crepitus. That distinct grating sensation you might feel, or sometimes even hear, when the bone fragments rub together. It's a definite sign of a fracture.
And you gently move the limb, it's possible, to assess for any abnormal movement and loss of function, though sometimes the pain is too much for this.
Correct. And here's another absolutely key insight. You must always examine the joint above and below the suspected injury. Always.
Why is that so crucial?
Because forces often transmit up and down the limb. You can easily miss associated ligament injuries or even subtle fractures in the joints nearby if you only focus on the most obvious injury site. It's a common miss. And alongside that, always perform a thorough neurovascular assessment. Check the pulses, the capillary refill, sensation, and motor function distal to the injury. Missing a vascular injury or nerve damage can have devastating consequences.
Okay, so we've assessed. Now, what are the overarching aims of treatment for any fracture? What are we trying to achieve?
It's pretty comprehensive. First, obviously, acute pain relief is paramount. Then preventing infection, especially vital in those open wounds we talked about. We aim for the restoration of normal joint anatomy as much as possible. That's key for both function and, well, aesthetics too. Maintaining the reduced position is critical to allow proper healing to occur. And then robust rehabilitation is necessary to reduce the risk of long-term loss of function and hopefully minimize chronic pain down the line.
That's a lot to juggle. What's often the most challenging aim in your clinical experience? Is there one that stands out?
In my experience, achieving that optimal restoration of normal joint anatomy, particularly what we call periarticular fractures, those near, or actually involving a joint surface that often takes precedence and can be the trickiest. Even small misalignments right on the joint surface can lead to significant long-term disability, arthritis, and pain, maybe even more so than in fractures just in the shaft of the bone. Getting that joint surface perfect It's a precise art and science.
That makes sense. Okay, so to achieve all these aims, we have a simple, memorable framework for fracture management. Reduce, hold, rehabilitate. RHR, maybe think of RHR as a three-part symphony orchestrated to bring the bone back into harmony, guiding the process from injury all the way to full recovery. First part, reduce E. The goal here is simple. Restore the anatomical alignment of the fracture or the dislocation. Get the pieces back where they belong. This can be done via closed reduction, which is non-surgical manipulation. It's often painful, definitely requires good analgesia or sedation.
Yeah, but the immediate benefits are huge. It reduces pressure and traction on the surrounding soft tissues, nerves, and blood vessels. It can also help tamponade bleeding by realigning the bone ends.
Or, if closed reduction isn't possible or sufficient, it can be an open reduction. This involves surgery to directly visualize the fracture and use instruments to put it back together perfectly.
Right. Then, once it's reduced, we need to hold it there. This means immobilizing the fracture to maintain that nice reduced position while it heals. Methods vary hugely. Could be splints, slings, casts, functional braces, external fixators where pins go through the skin into the bone and connect to an external frame.
Or internal fixation, right? Like plates, screws, or rods placed directly onto or into the bone during surgery.
Exactly. The choice depends entirely on the fracture type, its location, stability, patient factors. Lots of variables.
And the final, crucial part of the symphony, rehabilitate. This is often intensive physiotherapy and maybe occupational therapy. And it's so important to advise patients to start moving any non-immobilized, unaffected joints right from the outset. Prevents stiffness, maintains overall function.
Absolutely vital. This phase is all about getting the patient back to their full strength and mobility, and honestly, it often requires significant patient commitment and motivation. It's a partnership. Now, even with the very best assessment and management, fractures can unfortunately lead to complications. And we tend to classify these complications using two main categories: timing and location. So in terms of timing, complications can be immediate, occurring within the first few hours, early, occurring within the first few days or weeks, or late, popping up months to even years later. And classification by location. They can be local, specific to the fracture site and the limb, or systemic, affecting the entire body.
Okay, that's a useful framework. Let's look at some key examples across these categories. For immediate complications, locally, you might see, well, injury to major blood vessels or significant damage to soft tissues, nerves maybe. That makes sense, given the trauma. Systemically, a major immediate concern, especially with big bones like the femur or pelvic fractures, is hypovolemic shock from massive blood loss.
Definitely. Moving to early complications locally, one we always worry about, especially in forearm or lower leg fractures, is compartment syndrome.
Ah, yes, compartment syndrome. That's where swelling occurs within a tight fascial compartment, dangerously compressing nerves and blood vessels.
Precisely. It can lead to irreversible muscle death and nerve damage if not recognized and treated urgently with a surgical release, a fasciotomy. It's a surgical emergency.
Scary stuff. What else early on?
Well, locally, wound infection is a risk, especially with those open fractures we stressed earlier. And systemically, we worry about serious things like pulmonary embolism, a blood clot traveling from the leg veins to the lungs, and fat embolism syndrome.
Fat embolism. That's where fat globules from the bone marrow get into the circulation after a major fracture.
Yes, particularly with long bone fractures, like
Yeah.
the femur. It can cause respiratory distress, neurological changes. It can be very serious.
Okay, and then the late complications, months or years down the track.
Locally, the big ones relate to healing, or lack thereof. We can see imperfect union. This includes delayed union, where healing just takes much longer than expected. Malunion, where the bone heals but in an incorrect, often angulated or rotated position, which can affect function. Or worst case, non-union, where there's a complete failure of the bone to heal at all, creating a sort of false joint.
And I guess another big late local complication, particularly if the fracture went into a joint surface.
Is post-traumatic osteoarthritis. Yeah, damage to the joint cartilage at the time of injury can lead to arthritis developing in that joint years later. Phew. Okay, we've covered a lot of ground today, haven't we? From defining the different types of breaks and tears, understanding that whole intricate dance of healing, assessment, and management. You, our listener, hopefully now have the tools to describe a fracture properly by its mechanism, whether it's open or closed, its exact site, the shape of its fragments, and its displacement, and why those details are so vital for guiding treatment.
Absolutely. And remember that reduce, hold, rehabilitate framework, RHR, that's your anchor for treatment. It guides your decisions from the moment of acute injury right through to aiming for full recovery. Understanding these core principles and being able to categorize potential complications, immediate, early, or late, and local or systemic, that will truly empower you on your path as a clinician dealing with these common injuries.
Definitely. This deep dive, we hope, has given you a really solid foundation. Now, as you continue your medical journey, here's maybe a provocative thought to leave you with. We focus heavily today on the physical mechanics, the biology of healing, the x-rays, the surgical plans. But beyond all that, what role does a patient's mindset, their psychological resilience, their active participation and belief in recovery? What role does that truly play in the success of that critical rehabilitate phase? How might understanding the human psyche, the person attached to the fracture, further enhance your approach to healing and optimize patient recovery?
That's definitely something profound to ponder as you reflect on this deep dive. Thank you so much for joining us on the deep dive, and we look forward to exploring more with you next time.